Hello, and thank you so much for the kind invitation to speak today about tubal ectopic pregnancy. Historically, the diagnosis of ectopic pregnancy was sadly a retrospective one, often with women attending in extremis moribund or sadly having passed away. And either at the time of surgery or at post-mortem, one may have identified significant hemiperitoneum, distended fallopian tube, and signs of rupture. With the advent of laparoscopy in the 1970s, this started the change in the morbidity and mortality that we saw with ectopic pregnancy. And of course, then came ultrasound. And at the moment, in the UK, as an example, the mortality from ectopic pregnancy is generally low, 0.43 per 100,000 and that's quite low as compared with the low middle-income countries where one may find a mortality of up to 1 to 3%. And so this really remains a significant world problem. On the whole, nowadays, ectopic pregnancy is an ultrasound diagnosis, and we know that transvaginal sonography has a very high specificity and sensitivity in the diagnosis of ectopic pregnancy. And it's really based on the positive visualization of an extrauterine pregnancy rather than a diagnosis of exclusion and an inability to visualize an intrauterine pregnancy. And this is something we've really tried to move away from in the last few years. When we look at the ability of ultrasound to detect a tubal ectopic pregnancy at initial ultrasound scan, actually there's a 73.9% sensitivity for that. And when we look at follow-up ultrasound scans and ultrasounds overall, there's a very, very high sensitivity of 98.3%. So actually we know that ultrasound is a very good tool in the diagnosis of ectopic pregnancy. However, why are some ectopic pregnancy missed on initial ultrasound scan? Well, when we look at this very useful data, we know that when we do an initial ultrasound scan and we're not able to visualize an intrauterine pregnancy, nor are we able to find an extrauterine pregnancy, we name this term pregnancy of unknown location. And women are offered serial hormonal measurements looking at the serum beta HCG and progesterone at the time of PUL triage, and then repeated at 48 hours. And based on that, we will assign risk of a future ectopic pregnancy. And what we then see in women who have a PUL, who then subsequently get a diagnosis of ectopic pregnancy, compared with those who were diagnosed with an ectopic pregnancy at first scan, is that women diagnosed as PUL initially have a lower mean gestational age. They also have a lower mean serum HCG, but interestingly, a higher median progesterone level. And in fact, when we then look at the size of the ectopic pregnancy, that when at the time of diagnosis, they also had a smaller size of ectopic pregnancy when scanned afterwards. And so the question was, why are some ectopics missed on that initial ultrasound scan? And very simply, the data tells us that these ectopics tend to have a lower mean gestational age, a lower mean initial HCG, and a higher mean progesterone level at presentation. And so they're probably just too early and too small in the disease process to be seen, and are often identified later on subsequent imaging. All this data is really based on transvaginal ultrasound imaging. But what about transabdominal imaging? What data do we have? Predominantly, this is used in the lower resource setting in low middle income countries due to the lack of availability and at times the lack of sonologists with training in transvaginal imaging. And studies have shown that actually in good hands, transabdominal imaging can be used to detect ectopics, but often really what this can be is a very, very useful triage tool to then allow clinicians to then triage women who may need to be referred to a tertiary centre for further care. Interestingly, the more you look at the data in these types of clinical settings, you find that the overall mortality is high as 1.1% in this systematic review of the diagnosis of ectopic pregnancy in sub-Saharan African countries. Unfortunately, patients are more likely to present late, and so ultrasound cannot be often applied in these situations. However, interestingly, where ultrasound was applied, and it was unclear in the data whether this was transvaginal or transabdominal, what they found was that there was a substantial increase in the diagnosis of unruptured ectopic pregnancies when there was routine use of ultrasound, which means that we're less likely to see women attending in extremis and moribund. Therefore, it is a possible triage tool, as has been suggested by some data. Let's look a bit more at tubal ectopic pregnancies in terms of the demographics, the presenting complaints, the biochemistry, and the ultrasound findings, and then we'll move on to management. There can be a wide variety of ages and a wide variety in terms of history of a pregnancy, obstetric history. But in particular, I want to focus on the gestational age, as about 30.6% of ectopic pregnancies will present with a gestational age of under 6 weeks. This is really important because often there are attempts to try and triage scanning and waiting for scans to after 6 weeks. However, it's important to realize that in doing so, we may miss women with potential ectopic pregnancies. Presenting complaints is also important because often we tend to think about ectopic pregnancy as presenting with pain, but interestingly, 10% have no clinical symptoms and the third have no clinical signs. Just under a half will present with pain and bleeding, and about 20% will present with pain alone, but interestingly, 23% will present with bleeding alone. And there is guidance out there that suggests that in women who are bleeding alone in early pregnancy, that this does not warrant an ultrasound scan as their risk of ectopic is not considered high enough. However, the data would suggest otherwise, and bleeding alone can be a symptom of ectopic pregnancy, and so in my opinion would warrant an assessment in early pregnancy. What about initial serum beta-HCG? We know, again, that various attempts have been made to apply cutoffs to say that at certain HCG levels, one may be more likely to identify a pregnancy. However, this really is quite an outdated approach, and what we know from the data is that even in initial serum HCGs of less than 1,000, one can diagnose ectopic pregnancy, and about 41.7% of ectopics may present and be diagnosed and have an HCG level of less than 1,000. Interestingly, the lower the HCG, the less likely you're to see it at that first initial ultrasound scan, and the higher the HCG, you're more likely to diagnose it at that initial ultrasound scan, which makes logical sense given the data that we've previously described. What about the ultrasound-based diagnosis of tubal ectopics? Well, what we know is that we often see an empty uterus. The only exception to this is a heteroectopic, where we see a pregnancy in the uterine cavity, and extrauterine, which is exceptionally rare. We then will tend to see a gestational sac and CRL, which is often called a live ectopic pregnancy. And this tends to happen in about 5.5% of all tubal ectopic pregnancy. They tend to have a higher serum HCG. And of those, a percentage will have fetal cardiac activity. A smaller, about 20% will present with an empty gestational sac, or what's called a bagel sign. And these tend to have quite a medium-ish HCG level and have this classic appearance here, as shown in this middle diagram. About 62% of tubal ectopic pregnancies will present as an inhomogeneous mass. And you could see that in this diagram here, often with lower HCG levels. Of course, we mustn't forget that some ectopics will present acutely with women in extremis in pain, and it's possible to identify significant amount of hemiperitoneum. And one may not, in those circumstances, be able to fully identify a tubal ectopic pregnancy. In these circumstances, depending on the clinical situation, it may be critical to get the patient to the operating theatre and perform a laparoscopy if possible, or if not possible, a laparotomy, depending on the clinical setting. I would not instrument the uterus in this scenario until I have confirmed and that I have visualized an ectopic pregnancy. The differential of this situation is possibly a ruptured corpus luteal cyst that has caused internal bleeding. And so it's important not to disturb a possible intrauterine pregnancy. So in hemiperitoneum, where you do a surgery, I would not instrument the uterus until I've confirmed a tubal ectopic pregnancy. How do we measure tubal ectopic pregnancy on ultrasound? Well, this paper by Kuhan Raja is very useful and gives us just this type of information. It's very important in the inhomogeneous mass to measure the ectopic in 3 dimensions, going from the outside to the outside. When you see a gestational sac, so the classic bagel sign, they again have advised measuring the cavity inside, but also the whole trophoblastic ring in 3 dimensions. It's also really important to measure a hematosalpinx if this is visualized, and they've recommended 3 in 3 planes from inner to inner, from the inner wall of the tube. What about hemiperitoneum? Well, often one might see a little bit of blood in the pouch of Douglas. However, if you see hemiperitoneum or blood above the uterine fundus, then this is clearly a significant amount of blood. You may see this in the hepatorenal space or Morrison's pouch on transabdominal imaging, and if you see this, you can anticipate that there is greater than 500 mils of blood in the abdomen. However, often these are subjective measurements. It's impossible in these scenarios to know whether this is a tubal miscarriage or a rupture, and therefore one must manage these patients clinically. Consider symptoms, consider urgent blood test biochemistry, and of course, urgent surgical management. Overall, the management of tubal ectopics depends on a number of factors. Firstly, symptoms, such as the presence of pain, which may lead you to perform surgery as opposed to expectant management, for example. Ultrasound findings, so finding a live ectopic pregnancy with a heartbeat, would lead you more likely to perform surgery than any other form of management. Of course, the patient factors, any medical history or comorbidities, their specific wishes are very important, and fertility and their obstetric history and fertility history, and if this is a recurrence of ectopic pregnancy, which is important. You'd also want to think about the serum beta-HCG level and the trend in that level over 48 hours. And of course, thinking about the local resources in the clinical setting you're working in. The key prior to any management is ensuring that you are confident of the diagnosis prior to treatment. On the whole, outpatient management strategies are safe depending on the clinical setting you work in. Let's look first at expectant management. Well, we know from the data by Mavralos et al. That 30% of tubal ectopic pregnancies can be safely managed expectantly. And the average resolution time of the beta-HCG is about 3 weeks. How this looks like in practice is that if you see an ectopic pregnancy in a patient who is clinically well with initial HCG of less than 1500, that is not significantly increasing, and the ectopic is small, less than 35 millimeters, it would be reasonable to offer this management. You would perform a serum HCG and repeat this on day 2, so at 48 hours. And if there is more than a 20% drop in the HCG, you can predict that expectant management will be successful, and that this is 93% specific for success of this management. Often the HCG levels drop, but if you choose to repeat the ultrasound scan, it takes a bit longer for the actual tubal ectopic mass to resolve. If there has been a drop, of more than 15 to 20% within over 48-hour period, you would repeat this on day 4 and then weekly. And this is in accordance with NICE guidance that is available in the UK. If the HCG levels start to increase, or if women develop symptoms such as pain, all these factors need to be considered, and management needs to be tailored to the individual patient. In terms of medical management with use of methotrexate, again, I would urge you that you must be certain of the diagnosis. We tend to very rarely use methotrexate at a first scan. We tend to be sure of the diagnosis with serial scans and serial HCGs before offering a patient methotrexate. This is because of the significant harm and teratogenicity to any possible intrauterine pregnancy. So please exclude intrauterine pregnancy and be certain of that before offering methotrexate. We know in serum HCG levels under 1500, methotrexate is successful in about 83% of cases, and expectant management 76% of cases. But when we look specifically at HCG levels between 1000 and 1500, we see there that methotrexate has some value over expectant management, as expectant management is slightly less successful at higher HCG levels. It's really important, as I said, to exclude an intrauterine pregnancy. Make sure the ectopic pregnancy mass is less than 3.5 centimeters. You will not be able to give methotrexate if the HCG is greater than 500. Again, it tends to be contraindicated in live ectopic pregnancies if there are signs of hemoperitoneum or pelvic pain. Once you give methotrexate, we normally repeat the beta-HCG on day 4 and day 7, and we would expect a 15% drop between those two HCGs. And if there is, then we would see the patient weekly until the HCG falls to undetectable. In this period of time, they must avoid folic acid and alcohol, and of course avoid pregnancy for 3 months from the date of the injection because of the residual effects of teratogenicity. In that time, you would advise them to use contraception and advise barrier contraception such as condoms. I always warn the patients about these potential side effects, and they must be counselled about the risks of these things. When we look at expectant management versus methotrexate, there was some reviews of various randomized controlled trials performed in Europe and UK, Finland and the Netherlands and Brazil. And they found no significant difference between expectant or medical management for ectopic pregnancy resolution, tubal rupture, or additional treatment requirements or health-related quality of life. And therefore, the NICE guidance in the UK agreed that expectant management could be offered based on clinical suitability, assessment of risks and benefits, and patient preferences. In particular, in a clinically stable patient without pain who had a small ectopic pregnancy and a low serum HCG of less than 1500. However, in most of these randomized trials, the problem is that the serum HCG level was less than 1000, and the majority of patients included fell into that category. So one could argue that actually a lot of these ectopics may have resolved anyway, and therefore they didn't find a difference between methotrexate and expectant management. But this is the data that is currently available to us. There are some practical considerations when you're thinking about both expectant management and methotrexate. The patients must be able to return for follow-up. They must be able to access emergency health care if they have symptoms of rupture. With regards to methotrexate levels, that should be checked, as I said, on day 4 and day 7. And if there is a drop of more than 15%, then weekly until it's negative. And of course, if there are signs of rupture or the above is not appropriate, then we have to think about surgical management and access to surgical management. So clearly, this is really, really important. And we need patients to engage in this follow-up for their safety. And this needs to be discussed and assessed prior to agreeing this form of management. So we've talked a bit about expectant and management and medical management with methotrexate, and predominantly focusing on HCG levels of less than 1500 and greater than 5000. These management strategies are not advised and surgery is advised. But what about this grey area in the middle between an HCG of 1500 and 5000 for tubal ectopic pregnancies? Well, for these, we offer the choice of either methotrexate or surgical management. And they need to be able to be offered methotrexate. They need to meet the following criteria: no significant pain, an unruptured ectopic with a mass less than 35 millimeters with no heartbeat, no intrauterine pregnancy, and an ability to return and engage in the follow-up requirements. However, if you give methotrexate at these levels, we have to advise women that their chance of needing further intervention is increased, meaning their chance of rupture, their chance of treatment failure, and then needing further methotrexate or surgery is much, much higher. So we know that at these HCG levels, methotrexate treatment is more likely to fail. What about surgical management for tubal ectopic pregnancy? Well, clearly, if you have a hemodynamically unstable patient, this is going to be your initial first-line management, in particular if there is evidence of significant hemoperitoneum. If there is a live tubal ectopic pregnancy with a fetal heartbeat, again, this would lead you to offer surgery and recommend surgery, particularly if there is a large ectopic of greater than 35 millimeters and significant hematosalpinx on scan. Again, at HCG levels of greater than 5,000 and is definite, but again, a discussion to be had on a case-by-case individualized basis at HCG levels between 1,500 and 5,000. Laparoscopy tends to be the gold standard. Of course, that depends on the availability of laparoscopy and surgical experience, but this is normally the gold standard in the UK. And of course, you need to give anti-D if the patient is rhesus negative. There is a debate about salpingectomy or salpingostomy, but on the whole, we would recommend, in the presence of a healthy contralateral tube, that a salpingectomy is performed. And the reason for that is salpingostomy does not improve fertility prospects compared with a salpingectomy in those with ectopic pregnancy with a healthy contralateral tube, and may increase the risk of ectopic on the diseased side, the affected tube. So we would really only reserve salpingotomy in those women who had a diseased contralateral tube and you were trying your best to preserve the tubes wherever possible. In terms of your 1 in 5 women, if they did have a salpingostomy, may need further treatment if they have a salpingostomy due to the presence of persistent trophoblastic tissue, either with a salpingectomy at that stage or methotrexate. So this is important to consider. There have been trials performed to try and see if we can improve the outcomes of methotrexate treatment and improve success of that treatment. And this is a trial published in The Lancet, led by Professor Andrew Horn in Edinburgh, who used gefitinib, an epidermal growth factor inhibitor, alongside methotrexate to see if this improved success rates. But unfortunately, this didn't offer any clinical benefit over methotrexate alone and actually was found to increase minor adverse reactions. So for now, these are the treatment options are available, and we have to watch this space for any changes. It's critical to be mindful and aware that there is a huge psychological trauma that can be associated for women who suffer from ectopic pregnancy. And we know from data from Imperial College under Professor Bourne that in those with early pregnancy loss, be it miscarriage or ectopic pregnancy, there is a 1 in 6 women will suffer from significant psychological distress and PTSD symptoms. So it is important that we consider this when caring for women. We have to think about counselling, local services that may be available, and in the UK, women can reach out to the Ectopic Pregnancy Trust. We have to think about offering contraception for women who don't want to fall pregnant again, whatever their wishes might be in that sense, and this should be discussed with them. In particular, if they've had methotrexate, they're advised to avoid pregnancy for 3 months, so this is critical. We have to think about the high recurrence rate and therefore counsel women about that and warn them about their risk of subsequent ectopic pregnancy. And of course, we have to consider that if they do get recurrent ectopics, that this may impact management if there is a recurrence, and we may be more inclined to offer surgery in this situation. We need to offer them an early scan in future pregnancy. Normally, I would recommend a scan at 6 to 7 weeks if they are asymptomatic to hopefully confirm the presence of an intrauterine pregnancy, or, of course, earlier than 6 weeks if they experience any abnormal bleeding or pain. And this is critical. So, in conclusion, transvaginal ultrasound has a high sensitivity for the detection of ectopic pregnancy. The diagnosis is based on positive visualization of an ectopic mass. 75% of ectopics can be visualized on an initial scan, and those that are missed are initially classified as pregnancy of unknown location. Expectant management can be considered safe in selected cases, and methotrexate should only really be given when there is no doubt as to the diagnosis. Hemoperitoneum obviously increases the surgical urgency. What we do need is further data to understand the impact of the ectopic pregnancy morphology on outcome, the utility of progesterone, and of course, optimal diagnostic algorithm and triage in more resource-limited settings. And this is critical to enable us to improve the morbidity and mortality globally from ectopic pregnancy. These are two resources that I hope you find helpful, the Green Top Guideline and the NICE Guideline. And thank you so much for your attention, and I look forward to hearing any questions you might have. Thank you.